Thank you so much.
Yeah, the floor is yours. Yeah?
The micro too.
En de micro too. Ja, alles wat je kan houden in het leven.
First of all, thank you. Thank you so much for organizing this for me. It's a wonderful place. And I mean, the sofa looks like a comedy show. So it's going to connect some aspects of my personality for sure. Yeah, it doesn't look like a lecture, and, but I like it most like this. So it could be the coolest place I've lectured. So thank you so much. And thank you everyone that has taken a train or a bus or drive here to be here with me. So I need to give back this effort by being as useful as possible today. So we have around 4 hours together. It sounds like a lot, but it's not, because I have plans for today. So I need to explain lots of things, and I want to do it. I need to transform this into a conversation more than a lecture. I'm going to explain a little bit the theory, because some people are in the program, some people met me before, but lots of people don't know who I am and what is my program. Some people have watched some videos without the context online, and they need the context to understand what I'm talking about. And that's why I'm here, to share many things with you. So this is a plan. I'm gonna give as little theory as possible. So it's gonna be let's say 10 minutes. It's gonna end up being 30 minutes. And after that, I want to make it interactive, and I want to cater the lecture to your needs. That means that you ask the questions and I answer. And if there is more people of one kind of dystonia, we talk about that. And if there is no people affected about particular kind of dystonia, so we don't need to cover that. So in order to make the lecture for this public, I need to ask some questions first. Who is affected by any form of dystonia, and who is family? So let's start with patients. Can you raise your hand? Okay, good. Most of the public are patients. Okay, good. And then who is affected by cervical dystonia? Okay, good. Leg dystonia. Leg, 1, 2. Hand dystonia. Okay, who is affected by spasmodic dysphonia? Okay, Blepharospasm. Wow. Am I missing one? Oromandibular. Wow, the oromandibular community is big. Okay, good. And MAGE syndrome, facial. Yeah, oromandibular MAGE. Okay, good. And generalized. Okay, all in the same place. Good. Good. And who is affected by any dystonia that I have not mentioned?
Dystonic tremor.
Okay, dystonic tremor? Mm-hmm. Okay.
Shoulder.
Shoulder dystonia. Okay, elbow, shoulder. Okay, that's like upper limb dystonia. So, yeah, it's interesting because even in the program and even in the literature, and this, we can start with that. My name is Joaquin, and I've been researching dystonia for 30 years now. That's why this is an anniversary for me. And I don't like how things have been done in the last 200 years in the theory. So I would like to rewrite the book, and in a very humble way. Why? Because the book has been written in a very complex way and probably can be optimized. I come from a family of engineers, and it's like this obsession of optimizing things. And like this can be optimized. This is too complex, that can be approached in a way that can be simpler and more useful. So I think that it would be better to classify upper limb, lower limb. And there's some initiatives there. And so when we talk about hand dystonia, it's very difficult to find a person that is affected by hand dystonia that has a clear shoulder. It's like almost never exists. So, and if you have a problem in the shoulder, probably you have some tension the way down. So in the wrist and the fingers, if we test it, no? So yeah, so you are part of the family of hand, shoulder, arm. In the same way that people come and they say, I have toes dystonia. And in the program, and they say, should I follow the ankle dystonia program? I should name it lower limb, because it's the same program for hips, knees, ankle, toes, and you should train all that, because the network is always affected in that way. But traditionally, they have divided. And that's a real problem when we are reading, because it's confusing. But okay, so welcome to the group and also to the upper limb community. Okay, good. Okay, so we have a little bit of everything, and so it's good. I'm going to talk about everything today. I like that. Okay, so everything started in 1990s, when it's not that I read in a book what dystonia was. It's like my hand started acting funny and started feeling tremors there, and the fingers were not cooperating with me. So I was introduced to dystonia. So, and it has been a long way, and a few years later I decided to dedicate my life to research the condition. And my doctoral thesis was about rehabilitation, and I remember that I wrote a chapter about, dystonic tensions. And the doctor that reviewed the doctoral thesis deleted. Why? It's not interesting. So, but it was the seed of my entire work, my entire life was there. This chapter that I wrote when I was in my 20s, early 20s, and it was basically looking for tensions, where the tensions are created when a person has dystonia. And at that time, because I was affected by dystonia in the hand, but I was experiencing tension moving in my body. And I was mapping that. And it has been like 30 years until the theory has evolved enough in order to recognize that this is not as focal as we have been told. And it's a good thing, because now, it's not that we have more symptoms now, it's that we can talk about other symptoms now that were part of the condition and were considered comorbidities, which means that something else is happening to you. But now we know that it's normal that a person affected by Blepharospasm has problems breathing because the diaphragm mistends. Or now we know that the person affected in dystonia in the hand, it's normal that they have tension in the shoulder too. Okay, so I've been researching dystonia and how to produce improvements in natural ways. So that's basically the theme, the core of my research, because I've not been researching on pharmacological treatments or DBS or botulinum injections. I've been researching on what I call what else. When you go to the doctor the first time and you are diagnosed, they say, I'm not going to talk about the Netherlands necessarily. One thing that I think that is interesting about my profile is that I have traveled a lot and I have met people affected by dystonia worldwide. And so I have some insight in how dystonia is worldwide in different places. And then you start doing statistics. And you see that in many, many countries, the doctor says, these are the treatments that you have, 1, 2, and 3. And then I think that every patient asks these questions, and what else? And this has been my research. What else? What else we can do? Because we know the 1, 2, 3. And we're not going to talk about this today because you know it. And it's easy to find online. We're going to talk about the 4, 5, 6, 7, 8, 30, 40, 50. All the other options. So complementary, alternative, natural treatments for the different forms of dystonia. And then this can lead you to something that should not be called alternative, that is neurorehabilitation. But in most countries in 2024, neurorehabilitation is considered an alternative therapy, when it should be core therapy. And that's the conversation that I want to have. So, besides the 3 regular treatments that are offered almost everywhere, how we can design neurorehabilitation protocols that can produce benefits in people, reducing possible undesired effects, getting the best results with non-invasive ways. So, if we talk about natural approach, I accept the natural, and alternative, it should be complementary. So, okay, let me get into the entire concept. So, I'm gonna get into something very complex, that is the study of the neural networks that dystonia affect, and how we can rehabilitate those networks to reduce the symptoms that are a problem for you. Networks are different depending on the different dystonias, and they are also shared between dystonias. So there's a percentage of the networks that are different from hand dystonia or leg dystonia, but there's another percentage of those networks that is core, which means that we can have this kind of conversation that can be useful to anyone affected by dystonia. Because no matter if you're affected in an eyelid, in a hand, in a leg, there are some aspects of the theory that applies to everyone. And in studying that, you can develop a protocol that is general enough to be used by anyone affected by any form of dystonia. And then you can also design specific protocols for all the subtypes of dystonia. Okay, good. So I'm gonna be like a good instructor, I wish. So no lots of unnecessary theory, just get with images. So think about an orchestra. When you have an orchestra, if you have enough musicians, you will need a conductor. The conductor is essential because the conductor is going to tell you when to play or when to sing, when to stop, and also it's going to control the dynamics. The dynamics means that you're going to sing very loud or you're going to be quiet, but you're going to sing quiet. So this is very, very important. There is no proper function of the brain without the conductor. And dystonia affects the conductor. So another thing that we need to think about is this, the word pause, lapses, interruptions. This is a way, now is emerging a new theory of dystonia that I'm very fond of, that is actually talking about descending inhibition lapses as actually the core of the problem. And I will explain that and what this means. Imagine that is a Wi-Fi signal. So we are watching a movie on Netflix, and if the Wi-Fi, you have a good signal, you have 1, 2, 3, 4 bars, everything goes smooth, and you can watch it, and everything, sound and image is going, proper stream. If you get into 2 bars, maybe it's gonna be spotty, and if you get into no bars, it's gonna freeze. So this can explain how people experience the dystonia symptoms. If the conductor in the brain has interruptions, you may have like a spotty Netflix movie, which means you can get into tremors. So it's basically an interruption and a correction in a very fast fashion. Or you can have a spasm that comes and then it goes. If you have a very low, a long lapse, a long interruption, so your connection between the brain and the limb is interrupted for too long, you're going to have a strong spasm that is going to last for longer to relax. So that's something interesting. I'm going to explain it later, but remember the Wi-Fi signal as an idea. And then you have this one. It's also a good visual, it's the disconnection. So I understand dystonia as a disconnection syndrome. So basically rehabilitation is based on reconnecting pathways that have been disconnected. So if you imagine a fuse box like this one, so if one thing that has puzzled scientists for decades and probably centuries is that dystonia is episodic, which means that I receive thousands of emails of people telling me what is happening to them, and they suffer because they say, I can speak. I can speak when I'm talking to my cat. But then I try to talk to a human being and I cannot speak. What is going on? And that's very difficult to understand to a doctor. That's why dystonia was considered a psychological problem in the past, and now we know that it's neurological. So the thing is, these pathways that are necessary for producing voice, for voice production, to speak, in this particular patient, disconnect when he's having a crisis. So he's having a disconnection, and probably the disconnection is produced by stress. So if you get stressed because you're going to speak to someone, some pathways in your brain, some connections are going to disconnect. And this can produce the symptoms. So it's a neurological response, hands down. But it's interacting with stress response. There has been, new research is talking about something that is very, very important, that people affected by dystonia may have an extreme stress response. So we are sensitive, extremely sensitive to stress, and we overreact to stressors. And this can be producing interference in the brain. It could be not the only source of the condition for primary dystonia, but the main source of the condition. So a person that is calm may be able to speak, sometimes even walk or move the hand, or even have the neck in center, but as soon as they feel high stress, they can have way more symptoms. So this is a good visual to understand the concept. We were talking about conductors. So one main conductor of, that controls movement and the tension that you produce in your arms, legs, and your muscles is the basal ganglia. So the basal ganglia, you have read about dystonia. It's a main conductor that will guarantee that it's like if we simplify it to be didactic, so it's like a traffic light. You have a red light or a green light. So when you close the eyes, for example, you are closing, and then the basal ganglia needs to signal and say, it's enough, stop it. So it's a red light, so you stop contracting. So what can happen in dystonia? That you close your eyes, and you still have a green light, so you keep on contracting and contracting and contracting, and you cannot open your eyes, because you need to turn the page. You need to say, enough, move on. But if you don't do that, then you get stuck in that position, in the same way that if you contract the arm, the brain needs to say, it's enough, relax. But if the basal ganglia is not working well, at that moment you are having a crisis, you may contract the muscle, but then the muscle maintains the contraction. So the brain needs to be able, the basal ganglia needs to be able to say, turn the page, green light for you, red light for you, so relax the muscle, and it's not happening. And then you have one aspect that's extremely important. It's part of the new theories of dystonia that are not only focused on the basal ganglia, that are focusing also on the cerebellum, and it's very, very important. Cerebellum controls movement, corrects movements, and actually is one of the main conductors of movement. So I think that I was able to translate this well. I hope that this is cerebellum in Dutch, no? Okay, good. Okay. So let me get into, I'm going to explain all this in practical ways with examples. So a person affected by Blepharospasm first. So you're perfectly fine. You can even be and I've seen it, you can be a top gun, a high-level military pilot. So you cannot have better eyes than that. And you can develop Blepharospasm, or you can have a person that is an Olympic shooter and develop Blepharospasm. So the idea is interesting that in dystonia, you don't need to have necessarily any deficit prior to the onset of the condition. So some people were Olympic athletes before they were affected, so they have fantastic control. So they were the best musician that you can be, and they develop dystonia that they cannot move their hand properly. So doesn't mean that you are born with something that is affecting your movement by default. Is that something happens in the brain that is activated and is interfering with proper movement control. So the idea with Blepharospasm is that you start having dry eyes, and then you go to the doctor and they give you drops, and it takes years, and you start feeling stress and probably many other symptoms that are probably associated with what is called the sympathetic overdrive. So dry mouth, dry nose, probably problems breathing, skin problems, sleep problems. And then there is a moment that your eyelids start fluttering or fasciculating, moving fast, and your blinking is irregular, and there's a moment the eye closes. And then you go to the neuro-ophthalmologist and you are diagnosed with Blepharospasm. Let's start with that one. I don't believe that Blepharospasm should be called Blepharospasm, because Blepharospasm means spasm of the eyelid. And the problem with that is that after the diagnosis, the patient believes that the problem is just in the eyelid. So, and you take the eyelid. In the past, the eyelid was cut, or you receive injections in the eyelid. It's true that there's a problem in the eyelid, but it's not only in the eyelid. People affected by Blepharospasm, and this has been part of my research, they also have problems tracking, so moving the eyeball. They also have problems constricting and dilating the pupils. They also have problems accommodating, that's why it's difficult to read when you have Blepharospasm. Sensitivity to light, sensitivity to noise, movement sensitivity. So there are other things, so it's way more complex. So you need to study what is actually happening. So it's not Blepharospasm, we could call it visual dystonia. So how you would approach that, I think that it would be great in the future. Let's talk about the future. To say, okay, there is something going on in the brain centers that are regulating the vision, including the eyeball, the eyelid, and facial muscles are not doing well. We need to get into precise diagnosis, find exactly what is not working, and then you need to recover function. How? You need to find what is working too much and what is not working enough. And then in my approach would be naturalistic. It's like if you are closing too much and you are not opening, we will need to try to open. If your pupil is dilated, we will need to develop strategies to help your pupil constrict. If you are not focusing close, we will need to do exercises to actually engage the muscles that produce that. If your diaphragm has a spasm, we will need to do breathing exercises to treat that. So that would be the main concept, so recovering function. So that's why the program that I'm presenting today is called Dystonia Recovery Program, because recovery means something very specific. I'm not using dystonia cure program, it's dystonia recovery, because dystonia affects you in a way that takes from you part of your function. So one thing that can happen is that you can be affected, you can lose 10% of your control of the quadriceps, you can lose 20% of the control. You can lose control in 5%, 10%, 15%. So what is the recovery program? What is rehabilitation aiming at? Recovering function proportionally. So you get into a program in order to reduce your deficit, recover as much function as you can. So it's a progressive, extended in time process where you are recovering what you have lost. And for that, you need to know exactly what you have lost. And that's why I want to do demonstrations here. So I'm gonna do, I'm gonna diagnose function, no condition, function here. I'm gonna check how you are doing. And then we can get into exactly what I think that you should work on. Okay, good. So once that you know what is happening, we will get into neuroplasticity, which means that we can activate the neural networks that are firing below the threshold, so where those networks that are not working enough. And we can also, by training, we can help the brain reduce activity in the areas that are overactive. And that's basically the main concept of the program. So let's explain cervical dystonia. When you have cervical dystonia at the beginning, what you feel is tension, and you feel that you're restricting your motion, and in some ways, and it's difficult, it's painful. So you go to a physical therapist, and they try to stretch the muscles, they try to mobilize your neck, but you are not improving until there is a moment. Sometimes it takes years for the diagnosis. It has been estimated that in 2024 is between the time from the beginning of the symptoms to the precise final diagnosis, it takes from 7 to 10 years. It's crazy. It's way too long. Okay, your physical therapist will finally think, you know, we have been stretching the neck and it's not working well. So maybe something neurological, and then you're going to send to the neurologist. At the beginning, you thought that was something physical. That's why you were stretching the muscle and going for massage. And then the neurologist says, no, this is central. This is the nervous system. It's not the muscle. So it's misfiring in the brain. And then what happens is what I call the step back. The step back means that at the beginning you thought that was muscular, was tension in the muscle, a very simplistic approach, I understand. And then you evolve into something way more complex, like the neurologist is telling you, no, these are different structures in the brain that are misfiring. But then after that, you say, no, it's the nervous system, it's the brain. And then it's the step back. It's like, okay, we're gonna work, we're gonna basically, mostly, go after the muscle. So it's a step back, because I think that in the future people would say, okay, it's a brain imbalance, so we need to do a brain intervention. And there are many ways to do a brain intervention. And then a naturalistic approach is actually to get into function. The function, you know, I was answering a question before this conversation, and one question, you know, one part of the question was this rehabilitation or this approach takes effort. Everything takes effort. From if you want to ride a bicycle, it takes effort. You want to play chess, you need to play Mario Kart, it takes effort. The brain needs to invest energy, you know, and to learn anything, to acquire any skill. So rehabilitation is not different from that. So take rehabilitation as a skill, or something that you are training, or something that you are learning. It cannot be passive in any way, in the same way that you cannot ride the bicycle passively. So the introduction of leg dystonia is similar. So people may have, you may see the foot drop, they may see that they have spasms in the calves, that it's difficult to control the movement in the hip, that they start dragging the feet when they walk, they start, you know, sometimes they fall, and so, you know, they need to wait until they have a final diagnosis that is leg dystonia. And with hand dystonia, it's an interesting one because there are like 20 different kinds of hand dystonia. Yes, you have the typist dystonia, the musician's dystonia, the surgeon's dystonia, the dart dystonia, the baseball dystonia, tennis dystonia, basketball dystonia. And that, I think that all this was unnecessary, because it's basically an upper limb dystonia, but the fact that has been all these different diagnostic labels have been created is creating confusion, because people come and say, I have a pianist dystonia, I don't think that your hand dystonia program applies to me. And yeah, and then you look for research, and then they publish different research for writer's cramp and hand dystonia, which basically, in my understanding, is a hand dystonia in a person that is trying to write. And that's quite obvious to me. So, okay, let's get into neuroplasticity. So the concept of plasticity, is that the brain is way more flexible than we thought. And there are several mechanisms that have been shown that can explain why people recover function after dystonia. You have one that could be the simpler one, is the one that I was explaining before, that is neuromodulation, which means that you basically control the dial of the brain. If you have spasmodic dysphonia, that I didn't explain, if you have spasmodic dysphonia, you find that you are trying to speak and it's like your voice, you have spasms in the voice box and your diaphragm is not working well. And doing exercises, you find out that it's difficult for you to, when you inhale, it's difficult to hold there. Basically, you inhale and you do, it's like you don't have muscle to actually hold there. So there's a weakness there. And what happens with that is that we can say, okay, there's a hypoactive area. So we need to do exercises to potentiate those muscles and those networks. It makes sense to everybody, no? In the same way that if I have a spasm here in my biceps is hyperactive, is doing too much. By definition, my triceps is not doing enough. So you always find a hyper and a hypo. So in this case, my biceps is hyper, my triceps is hypo. So it's not doing enough. So what about stimulating the hypoactive muscle? By doing that, you are stimulating the hypoactive network that controls that. So doing exercises like that, you are training the ability to activate the muscle that is not properly activated, and by that you reduce activity in the muscle that has the spasm. So it's like upside down vision of dystonia, because dystonia has been designed as a spasm that happens in the muscle and is focal, and people say I have a spasm in the flexors. No, I'm doing that, I have a spasm there, but I read it in a different way because of training and experience. Like, okay, you are not doing enough, the opposite movement. So it's not that you have a spasm in the muscles that are closing the eyelid, is that the muscles that open the eyelid are hypofunctioning, they are not working enough. And it sounds logical to everyone. This completely changed the approach, because instead of trying to relax chemically or stretching the muscle that is doing too much, what we do is to activate the muscles or the networks that are not doing enough. So you need to look for the other side of the coin. So which networks are not working enough for you? So neuromodulation is like we don't necessarily look for the muscles that are working too much, because that's very clear. We look for the muscles, that's the networks that are not working enough. And by doing exercises of neuromodulation, we activate those muscles. So basically, if you have a foot drop, what is called plantar flexion, it's because you don't do dorsiflexion. So you will need to find ways to activate the dorsiflexion, the opposite muscle. Because there's a principle that we know in muscular physiology that actually says that when you contract a muscle, the antagonistic muscle relaxes, which means if you are able to lift your ankle and you do a dorsiflexion, the spasm that is produced in the plantar flexion will relax. This will happen, and that's basically neuromodulation. There's one main core. You will remember that when I start doing demonstrations, when I talk about that. The second thing that is interesting about plasticity is that we can also do what is called neural distribution. We can imagine that we have a business together and half of the room is working on translation, yeah? And now AI comes and is actually translating quite well. And then you have 20 people who were translating and now they do not have work. So instead of firing them, you're going to say, no, we are going to reassign those people to another department. Now you are going to do social networks and digital marketing, no? So this happens exactly the same way in the brain. What happens after conditions that affect brain function is that if some neurons are not working well, other neurons that were taking part in other functions can be recruited. So if the neurons in charge of you opening the eyelid are exhausted, you can even recruit other neurons to help with that function that before they were not into this business. So it's interesting that you can reassign neurons. That's fantastic, but it's actually another possibility and probably is happening to a certain extent. And then you have other options like neurogenesis that probably happens in some ways, but I don't think that we need to get to neurogenesis actually. I think that by neuromodulating, activating and training neurons and reassigning, you can get the results that people are getting. But it's a fascinating topic. It's like how, if I'm here, if I try to engage the muscles that are not activated, I'm producing changes in my brain. I'm producing sprouting, which means that the neurons are creating new dendrites to communicate with other neurons, and I'm producing new axons in order to, produce this network of connections and activations of different pathways. So we have been educated to think that in order to produce something as fantastic as that, like neurons changing inside your brain, or your white matter, the connectivity in your brain changing, or the gray matter changing, so that this is so fantastic that needs to be produced by an external mean. And actually it's not the case. It can be also produced, and it's actually produced internally. Your kids are home playing, they are changing the brain because they are playing. You are learning a language, your brain is changing because you are learning a language. So whatever you do is changing your brain. So we are not doing something fantastic here. It's something that you can do, with flip-flops, in a pajama. You are doing neuroplasticity at home. It's actually something that everybody can do, and it's actually happening. And it happened in Dystonia too. So it's just harnessing that capacity and finding the way to stimulate it. So an example, a person with hypoactive triceps will be in this spasm. So at the beginning, if you ask this person to open the elbow, it's going to be very difficult for two reasons. That's why when I do examples, I just explain the theory, enough theory for people to understand what happens. Dystonia is not only a muscular or motor disorder, it's also sensory. So it affects the way you feel the muscles too. So when a person is here, it's not as simple as saying open, the elbow, just do the movement. It's going to be difficult for two reasons. First, because this one is weak, neurologically weak. Second, if you have been affected for more than 4 months, 6 months, it becomes muscularly weak. In the same way that if you lie down on a bed in a hospital for 6 months, your legs are going to be weak because you didn't exercise them. So it's something that comes on top of that. So it's neurologically weak, muscularly weak. So you need rehabilitation, we understand that. But also, it's going to be difficult for the patient to feel the triceps. This is extremely important as part of my research, how we can make the brain reconnect those networks. It's not just exercising, and maybe this is the reason why physical therapy until the moment was not so efficient, because there were some pieces of the puzzle that were missing, and this is extremely important. You need to do what is called sensory stimulation, which means that we need to reconnect the pathways. So imagine that we have here a Bluetooth device. This is connecting with that one through a Bluetooth signal. They need to pair. If they are paired, I click here, something happens there. If they are not paired, I click here, nothing happens there. So your muscle and your brain, they need to pair. And the hypotonic muscle, the hypoactive muscle, is not paired. This is very important. We need to pair them. So what happens is, how are you going to contract a muscle that you don't feel? It's not yours. You need to make it yours first. So you need to touch it, you need to tap it, you need to try to connect with it. Once that you start feeling it, then you can start contracting it, and then the rehabilitation starts. Then you can recover the muscular strength, then you can recover the neurological connection. Clear for everyone? So it's like there are several steps there. So what happens in the neck, if you are here, in cervical dystonia, a very common case, this muscle here, there's the right sternocleidomastoid, is overactive, it's hyper, and the opposite is hypo. Okay, so if I ask you to turn to the other side, for you it's like a mystic thing. It's like, how can I do that? I don't even feel it. How are you going to connect this muscle? So you need to touch it, stimulate it, connect it. Once that you are able to feel it, the light is on, and then you can start training gradually. And then is the specifics of how you're going to do it. So this is part of my research, how you're going to connect that, first point. And second, how you're going to train it. If you try, imagine that you are able to connect it. And say, okay, I can connect it. I made the connection, I'm going to use it. And you feel that you cannot sustain it, no? And you try to sustain it. You try to sustain a contraction for 5 seconds, and you're not able to do it, and you feel frustrated and you stop. There's a science behind that. It's like what a muscle that has been just connected can do. And what comes next. So at the beginning you can do just this, fast motions, because you can produce a connection, but you cannot sustain it. And as you train it, you can hold it for longer. And as you can hold it for longer, you can hold it for even longer. And then after that, you can produce a smooth motion. And after that, you create neurological endurance. So this is very important. You need to explain everything to the patient in order to commit to the rehabilitation. Otherwise, they just try one exercise once and say, it's not working. And this is very important. That's why I need 4 hours, sorry, because I need to explain all this. Because otherwise, we do an exercise, you go there, say, I am able to do it. What comes back? It's not working. No, because you're not supposed to hold it in place for more than half a second at the beginning. In the same way that if you approach, you know, if you want to do a pull-up, and I think that's a very good example, if you want to do a pull-up, probably you cannot do it, most probably, or a push-up, and then you have a good instructor and he's going to say, no, don't do a push-up first, full power, do it on the wall. So you do a push-up on an angle, you do it, you know, just half a push-up, you do just one, you do a plank for a second, and you build up. And you are able to do 5 seconds and then 15 seconds. And then after several months, you do a full push-up. And after that, you can do 50 push-ups. So exactly the same when you are reconnecting the muscle. Yeah? Good. So, is dystonia a disconnection syndrome? And that's the question that has been in my mind for 30 years. If dystonia is a disconnection syndrome, we can connect what is disconnected, and by that we can train these weak neural networks into better function. And then we can get close to stabilize the function. And once you stabilize the function, you become less symptomatic or asymptomatic. So in a way, it's not such a different approach. I think that the problem of dystonia when we try to talk is that at the beginning of the study of the condition, we created a framework. And one thing that helps a lot is to think about the conditions. So if you meet someone with epilepsy, the idea of having an episodic condition is clear. So this person can drive, this person can dance, this person can do anything. But in the crisis, they cannot do it. And they can have a crisis in a year, and after 5 years without any crisis, they can have another one. It makes sense to everyone. We know it, and it makes sense. There's no big deal about that. But it's very difficult for patients to understand that dystonia can be episodic too. And it's even very difficult for people to understand that you can be fantastically well now, and then, you know, something happened in your life and you have a relapse. It's interesting to me. It's like, why it's so easy to understand epilepsy, and then when we think about a condition that is not epilepsy but is also episodic, it's like we don't read it through the same light. So thinking about the disconnection, we can stabilize that in the ways like having a person that is suffering from epilepsy, is epileptic, and you find a way to stop the crisis. Has been 10 years without a crisis, or 6 years without a crisis. Is still this person epileptic or is suffering from epilepsy? Yeah. but we have developed consistency in these networks in order to be asymptomatic. So we stabilize what was destabilized. Yeah? So this is a dynamic approach to the condition, a dynamic approach to rehabilitation. Because you cannot understand dystonia if you take as a model a broken bone. No? I think that it's better to approach it understanding it through the light of other conditions, like epilepsy, for example. So I explained this before, that you can do, I cannot read that. So basically, it's like that you need to reconnect the pathways, and they are going to reinforce what is hypoactive. And by definition, if you reinforce what is hypofunctioning, you will reduce the hyperfunction. And we will talk about this with special cases. In particular cases, that's going to be easier to understand to everyone. So getting into something interesting, these are functional MRI studies of patients of mine and what has happened. So this is before training, after training. So before training is that one, after training is that one. So what you can see, and you don't need to be a doctor to understand this, you can see there is less activity after training. What that means, and also one thing that is going to catch your eye, is that you can see both hemispheres, right and left. And before training, both hemispheres are activated. And after training, one hemisphere is mainly activated. What this means? Means that when you're in a crisis, this is a person affected by hand dystonia in the right arm and upper limb dystonia right arm. So when he's trying to move the affected arm, before training, both hemispheres are working, and they're working massively. Why is happening? Because there is a deficit. There is a piece that is missing. So what happens is the brain gets crazy about that, and it's going to try to help. So you're going to connect a vast amount, high intensity of other networks trying to help. So basically, it's like if you're arguing with your wife, and then someone knocks at the door, and it's the neighbor that comes to help. And someone else comes, and lots of people come to help into this argument, no? It's like, but the concept is like, you are not invited. We should be able to resolve this ourselves. But in the brain, this happens, and it's called compensation, which means that if you are trying to connect the muscle that is going to help me lift the pinky, if it's difficult for me to do it, the brain will ask the index finger to help, and then the wrist in the same arm, in the same hemisphere, and then the shoulder, and then the abdomen, and the toes. And then what is more bizarre than that, also the other side of the brain will try to help. So you're going to end up contracting the toes in the left foot in order to help you lift the pinky in the hand. Does it make sense? No. Is going to help? No, doesn't need to be. Compensation is just a desperate way to help you. So one main aspect of rehabilitation is understanding your compensation and optimizing it. I'm going to give you an example. A person affected by Blepharospasm, common case. Whatever happens one day. So you're perfectly fine on Tuesday, and on Wednesday, something happens. Dystonia is this brutal. So it comes out of the blue for many people. So you are perfectly fine. And then one day you find that something is awkward, something is difficult. And then you feel that your neck is doing this. You feel tension here. Okay, this is what you think that is happening. You start complaining about your neck contracting, but it's not necessarily what is happening. I'm going to tell you something that for me is fascinating because I research on it, but I think that should be interesting to everyone. The brain is barely aware, consciously, of what the brain is doing. So our conscious brain is just a limited portion of the brain function. So what has happened? That's why people need help, external help, to make you make sense of your own dystonia. Treating your dystonia without someone that is helping you understand it from outside. So it's easier for you to understand my dystonia than for myself to understand my own dystonia because I'm biased. Okay, so what happens? You feel this, and you think that there's a problem in the neck, and you're gonna swear that the problem is in the neck because the tension is in the neck. But you know what? The brain basically feels what has increased. It's no good at feeling what has decreased. I'm gonna repeat that one. If a muscle starts contracting more than before, you spot it. Everybody spots it. A hyperfunction, everybody spots it. But it's very difficult to feel, what is going down, what is working less than before. Okay, what has happened? This micromuscle that is in the eyeball, specifically it's called the superior rectus, is affected. It's a micromuscle. And by reducing function because the disruption that has happened in the brain, this muscle is not working as before, so your eyeball is dropping. Okay, just one eyeball, not even two. One eyeball is dropping. The eyeball drops. Okay, what happens if my eyeball drops? I don't know, because there are different areas in my brain. There's one area that I'm gonna say, your eyeball drop, and there's another area that are not necessarily deeply connected that's gonna say, we need to read, we need to look forward, yeah? So I need to look at you, but my eyeball drop. I don't know it. That's an interesting thing. So what I'm gonna do, I'm gonna try to engage my eyeball as before. So my brain is gonna say, okay, both eyeballs up. That goes through the oculomotor nerve in through the superior rectus. Very specific pathway. Good, both eyes. One eye is gonna do it, the other is not gonna do it. So the brain is gonna see that, and it's gonna say, uh-oh, something is not working. But don't tell the conscious brain because it's gonna freak out. We are gonna do something. It's like, don't tell mama that we broke this. No, nothing like this. It's like, okay, we're gonna do something, nobody's gonna see it. Just connect the neck, and it's fine. The neck is gonna save us, no? Pretend that it's not happening. This is called anosognosia. It's interesting. It's a neurological process that is not making easy for the patient to feel the deficit, because the brain is playing tricks to help you continue. The survival concept is correct. It's like, you are limping, don't think about it, just run. No? So, okay, you want to look up, you cannot do it, your brain, no problem, your brain has a solution for you. The solution is use the neck. You didn't even agree on that. It's not that you were informed about your eyes weak, we are using the neck to solve that. You didn't agree on that, that was signed on your behalf. Okay, good. And then you start doing this. After several weeks, you have pain here. You go to the physical therapy and nothing works. Nothing works. You can even go to the neurologist and they inject Botox here. It doesn't work. It's not there. So interesting. That's a real case. And there are many real cases like that. So if you understand the condition deeply, you say, wow, this is actually a problem in the eye. Very common. There's a percentage of people affected by retrocolis that actually have a problem in the eyeball, this micromuscle, but they are treated in the neck. Can you see that it's difficult to get results if you are treating the wrong spot? Another example. A person comes and has an index like this. This is not the secret, it's actually giving you precious information. The person comes like this, yeah? You are writing, you are playing piano, your index is sticking like that, no? You get crazy about that. It's like, what is going on? Wherever I try to move, this happens, no? And you go to the doctor and say, you have a problem in the index. Okay, that's obvious. It's like, it makes sense that my problem is in the index. So, and they can diagnose you as, you have a focal dystonia of the hand in the index, yeah? An extension, yeah? Let's kill this muscle, it's doing too much. And the question is, what if it's not? Well, this is an agreement of compensation that I signed the first 48 hours after the condition started. You know what? Lots of people are having a problem lifting the pinky. That was the one that drops, but you don't know it. And the brain says, without you understanding, say, no problem, we have it all controlled. We're going to help you lift the pinky with your index. So the pinky is healthy, the index is healthy and is compensated 24/7, compensated for the weakness in the pinky. So you inject the Botox in the index, it's not working. You stretch the index, no, it's not working. You have 0% chances to recover the function of the pinky if you work on your index because it's not affected. Okay, so what happens if you say, forget about that, that's compensation. What is not happening is this one. So you start weak, it's difficult, but you start recovering function here. By doing this here, you know what happens? This one says, thank you. I've been compensating for that one that is not working. And now I can rest, and it relaxes. So this is optimize, is the way to optimize rehabilitation, understanding all this. And for me, as a person that gets into obsession, for me it's like every case is like a chess play. Like find what is not working and how the brain is compensating. Sometimes it's easy to see, sometimes it's not so easy to see. Sometimes you have a problem in the voice box that looks like a problem in the voice box and the person is treated in the voice box, but the problem is not there, it's in the diaphragm. Sometimes you think that you have a problem in the jaw and there you go to a TMJ specialist and the problem is in the tongue. By doing exercises in the tongue, you relax the jaw because the jaw is compensated for the tongue. So all this is covered in the program, the rehabilitation program that's why it's puzzling. There's a percentage of people who just try the program for 1 week and they quit. You know why? Because they don't get what they expect. And it's difficult if you don't have the opportunity to talk, to explain that what you expect may be wrong. Because if you have a jaw problem, but just a compensation, it's like if you have a problem in the index and I say, forget about the index, train the pinky. And I say, well, you are crazy. No, I'm not. But the problem is if you came for index exercises, you say, this guy, I have a problem in index and doesn't want to treat my index. No? You need to understand the process. And I'm here to explain that. And it makes sense. I think that you are starting to get it. It makes complete sense, but it's difficult that your neurologist explains that. Or the person that is injecting the Botox, it's interesting when they are injecting, it's not Botox, you mean the sport, the injection. It's a blessing because controls the tension, reduces the pain. I'm not against that, believe me, it's a fantastic tool. But many times the injection is, you are treating the wrong muscle because we are lacking understanding of the chess play, what the brain is doing. Instead of going about the muscle, you need to know exactly which muscle is compensating, which muscle is overactive, which is underactive. Have you had this kind of pattern figured out for your case? That's the question. It takes a bit, but it's necessary that you understand what you are doing. Yeah, if you have a dystonia in your foot, and you are having a supination, and a flexion, plantar flexion, is because you are not doing dorsiflexion and pronation. It's the opposite. No? It makes sense. But someone needs to explain that to you. And this is basically it. So what happens if you activate what is underactive? You reduce compensation. That's why you can see there after training that the other hemisphere is not helping anymore. Because it's like this networks that were trying to compensate for the function without doing it. Because there's something specific about the brain. The brain is so good, so fantastically designed, there is only one pathway for one function. And that's good and bad. Which means that if I try to compensate, it's always a compensation. It's never as good as the original function. So, and because I'm a perfectionist, my idea, every time that is possible, I want to restore proper function and to activate the original network. Yeah? So, and if it is not possible, you can go for additional networks, which means when I started in the 90s, there was a famous rehabilitation clinic in France that they were based on compensation. which means that musicians were coming and they're saying, I cannot do this motion, I'm moving from the first knuckle. And they say, no problem, you can play like this. And they relearn. They were called, at that time that was called re-education for musicians. So they were relearning to use other muscles. And even though this has a place, because it helps you continue with your profession, it helps you get some money to pay for your rehabilitation or for your bills, that's not actual rehabilitation. Rehabilitation would say, okay, you cannot move the first knuckle, what we can do for you to move the first knuckle. Yeah, it's a different philosophy, optimizing. Okay, it's accepting the deficit but challenging it at the same time. Okay. So, this is the comparison between in the cortex. You can also see that not only the activation becomes way more precise, but also you can see on the right that a 10 becomes a 6. So it's also the intensity, the work that the brain needs to carry out. That's why when people, one thing that comes with dystonia is also exhaustion, because you are working way more than you need in order to produce a movement that they're actually not working well. So by engaging the original pathway and optimizing that, you consume less energy and you have more energy for other functions. I have treated some people who could tell me, affected in the hand, that's interesting to me. A person comes and says, I'm a marathon runner. So you need to have energy to do that. And I say, okay, let's start doing exercises. The person is not moving the pinky up. And I ask the person directly, okay, the problem is the pinky, we're going to move the pinky up. It's a normal pattern in hand dystonia. So move the pinky up. Okay, the person does this. Oh, I'm able to do it. Do it 5 times. Oh, yeah, okay. 5 times, 10 times, okay, the session is over, go home. The person needs to go to take a nap of 6 hours, 8 hours. Sometimes they go at 2 p.m. and they wake up the next day, exhausted. Say, you can run a marathon, but doing this 5 times has exhausted the energy for a delay. That's 100% true. Compensation, reactivation, rehabilitation takes loads of energy. That's important. And then the idea is by repeating it, you do the same thing with less effort and you consume less, you optimize what you get. And then this is to show that changes are not only in the cortex. Normally when we talk about the brain, normally they show you just the cortex. So dystonia, remember that we were talking about the basal ganglia and the cerebellum. So this shows that after training we have actually changed also the activity in the cerebellum. You can see the cerebellum there on the bottom. There's the huge activity in the cerebellum on the right and how it reduced to normal activity. So that's this storm in the cerebellum is actually not that it's working well. What it's telling you is that it becomes noisy because it's not able to precisely assign the signal. So it's interesting, it's like if you say that it's a cerebellum storm, it's not that it's going to work better. It's when this happens, it's actually that it's off. When it works less, it's more precise and more continuous. When it's not able to sustain, will go up and down. Good. And this is the cerebellum again in another image, the difference before and after.